I would like to talk today about the a clinical significance of copy number variants involving 59 and ACMG recommended medically actionable genes. And the reason I was actually interested in this topic because the recommendations that were made back few years ago, specifically addressing the reporting of these variants in a sequencing setting, but I can show you why the copy number variants are equally important. So what are the medically actionable genes? It's actually the secondary findings that we can see as the pathogenic variants unrelated to the primary diagnosis, but of medical value to the patients and their family members. Secondary findings commonly also referred as incidental findings, those that are not expected to be identified when people are looking at the specific patient's phenotypes and the sequencing results. So how common are the secondary or incidental findings? It's very interesting that when people start doing the whole exome or genome sequencing, the findings were really overwhelming because people were finding that medically relevant pathogenic variants were present in about 1% of the population. This was reported by the 1000 genome paper. There was also a paper that identified the Mendelian and complex traits conditions and exomes of European and African Americans, and posed a question by that time, what's supposed to be returned, because those are very important identifications in their genomes. So their findings indicates that about 15 risk alleles were present per individual genomes, which is not only the some of them dominant and may result in disease, but majority of them are autosomal recessive and put these individuals at the carrier risk. So about 45% of individuals in general population may have one of the pathogenic allele or being a carrier for genes that are used in the newborn screening genes. So these findings are not entirely rare, and opposite, they are pretty common. So based on that knowledge and the need for the reporting guidelines, ACMG work group was formed back in 2011, 2012, and considered the recommendations for reporting of incidental findings in the clinical exomes and genome sequencing. Back in 2012, the clinical exomes became as one of the tests available for clinical diagnosis, and the widespread of that test created a need for such regulations. So what were criteria for the inclusions and these group set of the genes that are supposed to be reported? First of all, definitely the severity of the condition for which patients carry the pathogenic variants, and the very clear description and characterization of the gene or conditions that available for particular gene. So, and another criteria was the preventive measures or treatment that is available. So you really want to report a gene for which you have no doubt the pathogenic variant will cause a condition. It is will be a severe condition, and if you identify that prior to the onset of the phenotype, you will have some treatment of preventive measures that may actually benefit patients who are carrying these pathogenic variants. So also one of the criteria was having the conditions for which patients remain asymptomatic for a long period of time, which means that the conditions might be a late onset and affecting adults rather than children, or children at the later teenager years. And this type of the findings can be easily confirmed, or the family members can be easily tested, which means the Sanger sequencing or any other testing approaches were already available by that time. So the first set of these secondary findings or medically actionable genes resulted in the list of 56 genes, and the first guidelines in 2013 was published proposing the reporting of this set of the genes. So this is the two papers that recommending the reporting of incidental findings provided by the ACMG work group. One, the first published in 2013, had a set of 56 genes, and the second version of secondary findings genes published in 2017 had 59 genes in the list. One of the genes that was previously published in the version 1 was removed due to the building up evidence for unclear, actually more pathogenicity versus than clear-cut findings, and was removed due to these aspects, and 4 new genes were added. So I just briefly go over these recommendations to set up a kind of the idea why and how these should be reported. So the recommendations were made that these findings will be reported by the clinical laboratories, and it should be reported regardless of indications for which the clinical sequencing was ordered. So the additional genes, this is not only limited to the 59 genes that were recommended, but laboratories may also provide additional genes for the reporting, that they have the certain policies to report and the reasoning for reporting. These incidental or secondary variants should be reported regardless of age, and should be reported on the constitutional sequencing, not on the tumor sequencing. So the reporting variants have to be recognized as the cause of the disorder, which means that the variants that are identified have to be classified as non-pathogenic or likely pathogenic, expected to be pathogenic, based on the mode of the gene action. And it is important to actually mention that not all of the gene, when the loss of function variants are found, may be relevant and cause the conditions. And this is important consideration also when we are talking about the copy number variants. So from another point of view, despite that recommendations were made for the responsibility of ordering clinician and team to provide comprehensive pre-test and post-test counseling to the patients, this is not always a possibility, or this is not always actually considered to be necessary at the actually beginning of the clinical diagnostic testing by exome genome sequencing. So it became more clear that the patients or family may actually opt out of not reporting such findings, but in the majority situations, there is a stepwise process for which patients may decline at the time of the consenting for testing, and then actually request this finding being released to them. Again, it's a very important, and it's highlighted actually in a red box, that these recommendations were made specifically for the testing by sequencing, which focusing on the point mutations and small insertions and deletions that can be actually detected in the by the sequencing. So just in a summary, the ACMG secondary finding version 2 genes recommends reporting incidental secondary findings, which is the sequencing variants. And because of the sequencing limitations technology in detection of the structural variants of the repetitive sequences or the triple nucleotide repeats, genes that are caused by this type of the rearrangements were not included. So the patients should be allowed to opt out of receiving secondary findings, and there is some counseling and consenting happens before the sequence is performed. So the 59 medically actionable genes should be reviewed, and the work group proposed that there will be updates annually, and the second version added another criteria that those genes that are reported have to have some intervention or some kind of a benefits of detection, simply because in the set of actionability, should be a method, or should be a process. So we're not reporting something that we cannot act on. So here is just a few snapshots from the table that was published in both recommendation guidelines. And the purpose of this for me to show just to see what genes are included. There is a big set of the genes that are associated with predisposition to cancer, including hereditary breast and ovarian cancer, Li-Fraumeni syndrome, Lynch syndrome. There is a set of the genes that are associated with familial thoracic aortic aneurysms and dissection, such as Marfan syndrome or Lloyd-Dietz syndrome. So those patients may not have a symptoms unless there is a sudden thoracic aneurysm rupture, and the patients are at risk of the cardiac failure and death. There is also a small set of the genes that are associated with metabolic conditions for which the phenotype may be built over the time and can cause irreversible damage. So preventive of those conditions are highly recommended. So if we are looking at the 59 secondary finding genes, there is a cancer predisposition genes. There are total 25 of them. The sudden cardiac arrests gene that associated with no actually phenotype and asymptomatic, but the patients are dying from the sudden cardiac failure. So those are 20 genes included in that list. The thoracic aortic disease, 7 genes, and the metabolic disorders also contain 7 genes. So it's a breaking down by the percentage. So as you can see, the majority of them cancer predisposition and sudden cardiac arrest genes. So I just want to go back to the limitations and interpretations of incidental findings. So again, back to 2013, when the first guideline was published, the prediction of copy number variants or structural abnormalities, repeat expansions were not really designed in the pipelines for exome genome analysis. And the prediction from this testing was not accurate. So the genes that are associated with such conditions were all dropped out. And also the copy number variance, or the recommendation for copy number variance, was not really put it at those guidelines, simply because limitations of the technology. So I just want to bring your attention to one particular condition that might be very important to realize. I want to talk a little bit about ornithine transcarbamylase deficiency, or OTC deficiency. It is the most common urea cycle disorder, and defects in OTC leads to reduced ammonia incorporation, resulting in hyperammonemia. Ammonia is especially damaging to the nervous system, and neurological problems occur in many individuals. It's also causing the progressive liver damage, skin lesions, liver cell carcinoma, and actually not only affecting males, simply because this is the X-linked conditions, and the males with these conditions rarely survive over a few days of life. But it's important to realize that females are carriers for these conditions, and about 15% of the females who carry abnormalities in OTC gene will be symptomatic, and the presentations of this condition will be different, and might be depending on the some life stress, like the body stress events, such as malnutrition, some of the infections, pregnancy, and also diet and exercise. So from that standpoint, females are commonly asymptomatic and not aware of their condition until they until they have a damage and multi-system damage. So from another hand, the current treatment includes low protein diet, a liver transplant. There's the preventive measures and the prophylactics with the screening, and also monitoring of the ammonia level, and monitoring for the neuropsychiatric conditions and the behavior issues. So if you're looking at the molecular genetic testing for OTC deficiency, for example, and this is the tables from a gene review, you can find them online. The OTC caused and 60 to 80% by the sequencing variants, but up to 10%, this condition is caused by deletion or duplication on the X chromosome. Very similar situation is for a Marfan syndrome, for which deletion and duplication is the cause for about 5% of the patients. So based on that information, we had questions related to our specific group of the patients. Can microarray analysis reliably detect copy number variants involving secondary finding genes? Because as I showed you, the deletions and duplications are a set of the abnormalities that can be pathogenic. So when we have a deletion and duplication, what is the clinical significance of these copy number variants in the pathogenesis of medically actionable conditions? Is every single deletion or duplication required reporting? Of course not. So which one of them required, which one not? And one of the observations were made that whenever clinicians familiarize themselves with the set of the medically actionable genes, and they see that gene in the microarray reporting, they are actually jumping in an action without the clarification if this copy number variants is really associated with the pathogenesis or not. So we were observing such incidents, and this has prompted our investigation. We also want to know if there is a hotspot for chromosomal regions. that will have higher risk of copy number variants, and that will involve the secondary finding genes. So we actually were surprised that there is no ACMG guideline for reporting of copy number variants for these genes. And even there is a multiple guidelines for the microarray reporting. It is really not specialized what set of the genes might be reported or how laboratory can handle these copy number variants. So in some of the situations, we questioned that reasoning. Are all of the findings going to be secondary or truly incidental? So would some of the patients really have the clear presentations for which they have been tested? And can we call them secondary, or this is going to be a truly incidental discovery and may impact the family members? So again, in majority of the settings, the counseling for the microarray secondary finding is not really established. So we do not have such a consultation, pre-test, post-test counseling as we have for the sequencing. And is there is a really a correct or doable as opt-out option for such situation? Is that really benefit the patients if they are really opting out and none of the family member are aware of the findings? We also were asking if there might be a different set of the copy number variants related genes, not what was really reported by the ACMG guidelines based on the sequencing results, but maybe just based on the copy number findings. So there are a few more examples of the genetic testing for which we investigated the copy number variants. As you can see, for TGFBR1 gene, the sequencing variants actually might be identified in 100% of the cases, although it's not really clear at the point that deletions or duplications are going to be causative for this disease, as there is a specific positioning of the genes in the genome, and deletions are not common overall. So there is no really many patients to have that genotype-phenotype correlation. So for another instances, you can see that for the cancer predisposition genes associated with Lynch syndrome, MLH1 gene is deletions and duplications causing the disease in up to 10% of the patients. For MSH2 gene, it's more than 20% patients. And for EpCAM gene, there is 100% of the patients that would be really caused by the deletions or duplication in that area. So there is a definitely higher variability of the copy number variants, and some of the genes really caused by copy number variants rather than the sequencing defects. So what do we know about the copy number variants and pathogenesis of Mendelian conditions? First of all, the chromosomal microarray analysis has been used as the first-tier test in patients with neurodevelopmental disorders and congenital anomalies, simply because it yields the pathogenic copy number variants in up to 20% of affected individuals. So definitely copy number variants are one of the major cause of some of the conditions, not only Mendelian, but the chromosomal genomic disorders. We know that whole gene duplications or deletions, those copy number variants can be responsible for up to 80% of the molecular findings involving dosage sensitive genes. This is not all of the genes, but the subset of the specific genes. We know that intragenic copy number variants, those that involve some exons in the genes, so the extra copy of exon or missing exon, actually account for about 10% of disease-causing variants. And those not always can be detected by the sequencing technology, but can be detected by the copy number variant analysis by microarray testing. Reviewing the 59 set of the genes, I showed you many of them autosomal dominant, and actually many of them are dosage sensitive, which means that the extra copy or a loss of copy may cause a disease. So another consideration when patients are tested by chromosomal microarray analysis, which is the first tier, they and found the pathogenic copy number variants, they may not be tested by exome and genome sequencing, which means they will be not having that opportunity to really act or protect relatives from these conditions if they have copy number variants in the medically actionable genes. So up to date, many clinical actually laboratories adopted the pipelines for the detection of copy number variants together with the sequencing variants, but the copy number variants may not be reported the same way as the sequencing variants, again, because of the possibility of pathogenic effect may not be the same. So when even in the sequencing, people discovering copy number variants, it's not always clear if those variants have to be reported or how they have to be reported. So as I can show you that copy number variants are actually equally important for returning. However, there is no guidelines exist for reporting copy number variants and medically actionable genes. So all of these prompted our investigation to see what exactly we are talking about, how many patients might be affected, and what are the consequences of the copy number variants for such conditions. So we evaluated 59 genes, broke them down in 4 categories: the cancer predisposition and the thoracic aortic dissection disease, the sudden cardiac arrest genes, and the metabolic conditions, as I showed you before. We located each gene to the chromosomal position, which means that we know where they are physically located, and this may cause the predisposition for the certain deletions, duplications, or for the certain genomic rearrangements. This is also related to the band position where they are located. We looked at the genomic size because that's important. If the coverage of the microarray is particularly sufficient to detect these copy number variants. And we look also what are the coverage in the current oligonucleotide probes on microarray, because not all of them might be even covered by microarray for a sufficient detection. We looked at the haploinsufficiency and triple sensitivity scores to identify genes that would be having a pathogenic effect when they are present in a single copy, haploinsufficient, or if they would be having a positive pathogenic effect when they present in 3 copies. So there's nothing on the sequencing level, but just dosage of the genes a cause of the disease. So we also looked the effect of the copy number variants, and particularly intragenic copy number variants, on the gene function, how gene is actually operating, and what is the mode of action for each of these genes. And based on this actually analysis, we identified the conditions for which the pathogenic variants would be causing the disease, or the copy number variants would be classified as pathogenic. And we looked in a set of our patients with copy number variants. It identified the patients who have this type of the abnormalities. So here is just an example of our table with the cancer predisposition gene. You can see each gene is given the band, chromosomes start in end position, the size, the haploinsufficiency score as sufficient or limited based on the available data and evidence from clinical practice. So we had these pathogenic copy number variants identified. So for example, if the gene is haploinsufficient, that entire gene deletion is causing the disease. It's also true for the intragenic deletions and possibly duplications when these intragenic copy number variants will lead to a frame shift and the loss of function effect. Same as entire gene deletion. So interestingly that we looked at the drug triple sensitivity and none of those genes as expected had no zero triple sensitivity score, which means that when you have an extra copy, it's not a cause of the disease. Here is the similar tables for the sudden cardiac arrest and for the thoracic aortic dissection. So for each gene, we evaluated available evidence, the clinical reports, presentations, mode of action, functional assays, and so on to come up with the set of the pathogenic copy number variants that might be seen in the patients and be associated with the disease. Again, this is the table for a metabolic condition. So overall, we identified that out of 59 genes, no pathogenic copy number variants were reported in 8 genes. So those are truly variants that are associated with the sequencing variants. 14 genes only cause the disease when they have the copy number variants involving intragenic regions. So the extra deletions or duplications may result in the truncated protein or altered protein that are actually has a gain of function effect. And that's a possibility for these copy number variants affecting this gene function. Whole gene deletions were assigned to 36 gene, and whole gene duplication, we found only one gene that was reported. This gene is PCSK9, for which whole gene duplication been reported as pathogenic and associated with severe hypercholesterolemia. So this is the only gene that we detected as the clear evidence for a duplication caused by the whole gene duplication. So two genes, TGFBR1, which is a cause of Loeys-Dietz syndrome, and MYH11, which is the myosin heavy chain 11, were implicated in autosomal dominant aortic aneurysm, and duplications were proposed as the possibility for the thoracic aortic aneurysm or dissection, but they were not sufficient evidence and not yet established as the real cause. So we screened data from our database of the patients who had a microarray, and out of almost 9,000 patients who had comparative genomic hybridization with the SNP chromosomal microarray, we identified 23 patients that had a copy number variance that would be potentially reported based on our evaluation of the copy number variants for each of the genes. We also looked at the coverage, as I mentioned, and you can see on this plot in blue, these genes are broken by the category cancer predisposition, sudden cardiac arrest, a thoracic aneurysm dissection, and metabolic conditions. And every set, we had some percentage of the genes that were not enough covered, did not have sufficient coverage for detection of the copy number variants, either because the gene itself was small or because there was not enough oligonucleotide probes to cover that region. We found in the pink the number of the genes that are affected by copy number variants. You can see 5 in cancer predisposition, 8 in the sudden cardiac arrest, 3 in thoracic aortic dissection, and 1 in metabolic condition. So overall, we found 17 genes out of 59 that were affected by copy number variants. So if we are looking actually at the normalizing each of these group by the total number of the genes in each group, you can see that 20% of the genes among the cancer predisposition had the copy number variants in our patients. 35% of the genes for the sudden cardiac arrest had the copy number variants that are deemed to be either known pathogenic or predicted to be pathogenic. 36% of thoracic aortic dissection and 9% of the metabolic conditions. So about 70% of the patients in our group had actually copy number variants in genes associated with cardiomyopathy, channelopathy, thoracic aortic aneurysm dissection, and were at the increased risk for a sudden death, which is a quite interesting finding because we do not see these commonly or do not think about this commonly when we're looking at the microarray presentations. So we looked at the hotspots and tried to identify where might be a hotspot for copy number variants, and that includes the secondary finding gene. As you can see, there is one chromosome 10. This is particularly megabase deletion. These deletions, we identified 3 patients with almost identical size deletions in that area. Deletions in these regions are mediated by the repetitive segments or low copy repeats. And this is why the unrelated patients have the similar alterations. And the critical gene, bone morphogenic protein receptor type 1A, is included in this deletion interval. And the individuals with these deletions, besides some of the intellectual disability and dysmorphic features, also are at risk of developing juvenile polyposis syndrome and characterized by hamartomos, gastrointestinal polyps, and gastrointestinal cancers. So it's also associated with hereditary mixed polyposis syndrome. So as you know, that patients who are having the intellectual disability and dysmorphic features would not be really looked or suspected to have a cancer predisposition, which can develop later on in life. And that's as important as it's truly secondary finding in this condition and have to be monitored when identified. So this is the table that we included in our paper, and you can see that we have 3 patients with deletions on chromosome 10 involving BMPR1 gene with the cancer predisposition. We had 4 patients who had deletions involving DSP gene, and that gene is associated with the sudden cardiac arrest. Among these patients, the child as a PM6 patient and his father who is PM7 patient. So again, patient PM6 was evaluated for the unrelated to cardiac findings phenotype for a bipolar disorder, migraines, myopia, astigmatism, while his father had a very severely presentations in the cardiac function. He had atrial tachycardia, arrhythmia, which is actually one of the signs and pre-existing condition for a sudden cardiac arrest. So based on the analysis of the child, father had been tested and found to have the same small deletion, which was about 228 kilobase in size, and was diagnosed. And based on these findings, he had the prophylactic measures and the some of the treatment. We identified two patients with the chromosomal 7q deletion, and those are terminal deletions, which is the terminal regions of the chromosome are more prone to deletions and duplications when they have some additional rearrangements. So not surprisingly that we have two patients with the different size deletions of this chromosome. And we also identified interstitial deletion involving SMAD4 gene, this cancer predisposition. Again, those patients were not evaluated for cancer predisposition, but evaluated for developmental delay, dysmorphic features. So this is the truly secondary findings and relevant to the patient phenotype and possible development of cancer predisposition or the outcomes of the such as like cardiac arrest and the sudden death. So we also, I mentioned that two genes, one of them MYH11 has been proposed when the duplication happens may cause some of the thoracic aneurysmal susceptibility to this condition. So we evaluated the copy number variants involving this specific gene. Interestingly enough, so the MYH11 encodes a protein myosin 11, and it's a component of myosin heavy chain and smooth muscle. And mutations in MYH affect structure and assembly of myosin thick filaments. And the mode of action is through the dominant negative effect. So from that standpoint, the copy number alterations are not really expected to cause any condition or be pathogenic for the cardiac presentation. So the pathogenic variants were reported as in-frame deletions, twice-site substitutions, and those are very well-known cause of familial thoracic aortic aneurysm. But what we did, we looked at the copy number variants in this region. So MYH gene is surrounded by repetitive DNA sequences, and it is commonly incorporated in the microdeletions, microduplications findings, and seen in about 1 out of 2,000 individuals in general population. So copy number variants in patients with adult onset thoracic aneurysm has been reported by a single group as involved as duplications were enriched and in adult population, and those were 10-fold higher frequency in the patients with thoracic aortic aneurysm. So we looked at the our cohort. We identified 48 unrelated patients with copy number variants in this region. 14 probants had the microdeletions, and 34 had micro duplications. And out of those 34, 27 had isolated gains, and this is what we focused on because we don't want to effect of any other copy number variants on the phenotype. So we looked at these 27 patients with isolated gains. So as expected from the mode of action of MYH11 gene, none of the patients with the deletions had any evidence of aortic dilatation, aneurysm, or dissection. And surprisingly to us, 8 out of 27 patients, which is about 30% with duplications, had cardiac and vascular anomalies. Some of the patients, one of the patients actually was died due to the sudden cardiac arrest, and another one had aortic dissection. Those were children, not adult patients. You can see in this figure, in blue, the regions of the duplications that we detected in the position of the MYH gene is in the outlined in red. And the number of the patients with the same size duplications are put in these blue rectangles. So you can see some of the regions are bigger, some of the smaller, and this is all also reflected by the copy number variant, segmental duplications that outlined in yellow blocks above the copy number variants. One of the patients with the smallest actually duplication, which is on the bottom of that figure, had the duplication and the breakpoints. It was not really mediated by the low copy repeats, but duplication breakpoint was located in the middle of MYH11 gene and duplicating a 5' and the part of the gene. So that is potential for creating an extra copy of the truncated protein. This duplication was found in both mother and her daughter, and both of them had the cardiac presentations and extensive family members with the cardiac arrest or the aortic dissection. So the duplication in this situation is 100% pathogenic. So it's important to say that intragenic copy number variants, an interpretation of the intragenic copy number variants versus whole gene deletions should be very different. In 14 out of 9 genes, we have this entire gene deletion or duplication when the entire gene deletion and duplication was not associated with the phenotype, but the smaller copy number variants inside of the gene are the cause of the disease. And it's important also to know, I mentioned you the deletions involving chromosome 7 telomeric distal region. These regions includes 2 genes, and one of them is associated with copy number losses. The KCNH2 gene, when it's deleted, is pathogenic, but the PRKAG2 gene is only pathogenic when there's a copy number variance involving individual exons. So when actually the large deletions, duplications present, duplications will not cause the disease, but deletions will only associate that with one of the gene, but not another. So that's important considerations when we're looking at the large genomic abnormalities. So those partial gene deletions, duplications require evaluation of gene structure and possibility of the truncated product being present. So it's not just simply involve the gene and this is the cause. 30 out of 59 genes did not have the coverage necessary for detection of intragenic copy number variants, and those includes 11 genes who are that are actually have the mode of action as intragenic copy number variants expected to be pathogenic.
Sorry to interrupt. You have 2 or 3 more minutes.
Yes, that's almost my last point. So this is the table for which we arranged every single gene in our publication based on the chromosomal location, because this is helpful for the laboratory personnel to find these genes and actually locate them and interpret them. And going back to our considerations, can the microarray analysis reliably detect copy number variants? Yes, but not all. there is a clinical significance. As I showed you, there is absolutely clinical significance for the copy number variants in these situations. There is a hotspots for the recurrent alterations. There is still unanswered questions for the counseling of these individuals undergoing microarray analysis. And there is probably a different set of copy number variants that have to be copy number variant related to be medically actionable in the microarray settings. So in the conclusions, there are 1 to 2.5% of the sequencing variants found among the patients undergoing the sequencing, and there is about 10 to 20% of the copy number variants that are pathogenic for the same set of the genes. So the reporting of the copy number variants is equally significant, and there is a necessity for a development of guidelines for returning of these copy number variants in both microarray and NGS platforms that actually incorporating the copy number variants reporting. And this is not always easy and requires really the a solid information, because we are reporting this copy number variants on asymptomatic patients. And this is not the same as reporting the findings in the affected patients. So this paper was published. I have the PMID included, and I thankful to patients and their families who participated in this study, the staff of the Pittsburgh Cytogenetic Laboratory for their assistance, and my co-authors and collaborators for their input and investigation for these patients. And thank you very much for your attention. I would like to hear your thoughts, comments, questions, and probably how you would approach to your patients, because there is still a debate, what should we do with this copy number variant?
Thank you so much, Dr. Yatsenko, for a nice talk. And for the audience, if you have any question, please feel free to use the chat function or unmute yourself to ask a question. Okay, and maybe I ask a first question first. So for the CMV calling, I know that you mainly use the CMA technology to identify the CMVs, and you also mentioned that some identified CMVs we cannot use whole exome sequence or genome sequence to confirm that. So what could you give us some comments about what about if we use non-read sequence like PacBio's or LiloPol non-read sequence to identify this kind of CMVs, how that will help to identify the causative CMVs?
So I think this goes back to a total efficiency and the in detection of copy number variants by sequencing. And in some area, it's just impossible simply because of the genome architecture, the presence of the pseudogenes and the polymorphic areas. So this is just a simple limitations by exome sequencing or genome sequencing in detection and reliability of detection of those variants. But I think from the multiple actually bioinformatic pipelines, the copy number variants are much improved in the sequencing detection. And because of that, I would assume that ACMG will come up with some guidance or some recommendations how to actually report this. I know that ACMG had a guidance on the reporting copy number variants, incorporating the knowledge about the 5', 3', intragenic copy number variants, and so on. So they are moving toward these directions. But in the sequencing, I think the knowledge of the genome is one of the important parts, but also the the bioinformatic pipelines or bioinformatic approaches is another how you can differentiate overall assignment of the sequence from the pseudogenes or non-functional gene and really identify the correct copy number. So that's a way to go.
Thank you. Any other question from the audience? All right. If not, thank you so much, Dr. Yatsenko. And I think that feel free to use his emails. I think Dr. Yatsenko actually put an email here. So if you have any question, you can also ask her by email, I think.
Absolutely. Thank you so much. My email is on the bottom of the slide. And if you have questions, please feel free to email me.
All right. Great. See you guys.